Hello, and we are back with human behavior. And the topics this week are to do with psychological disorders or psychopathology. This is when um, your behavior, emotions, or thoughts become so unusual, so disturbing, and so interfere so much with ordinary functioning of life that uh, you know it's decided, and we'll come to who does deciding. It's decided that something needs to be done, and you cannot continue as you are, and some return to a different way of being. Efforts are made to get there through therapy or through medication or something. So first, we can talk a little bit about something very important, which is when do we call something a disorder? Um, because, of course, human behavior is very variant. Um, in everyday life, perhaps we think of psychological disorders as being more strange and more uncommon than they actually are. So, um, it's true that thoughts disorders like schizophrenia will make people think and act in very unusual ways. But on the other hand, anxiety disorders or mood disorders like depression are, on the one hand, very common. Prevalence rates are 10% for some of them. So that means it's very likely that you know someone who's been through it. Um, and also, in the case of these disorders, they are really continuities in a much more extreme way of something that we all are familiar with and experience. So they're not that unusual. So everybody's had a sad day or a sad couple of days. Um, and it's a continuation of it when it becomes very extreme to the point that you're not being able to get out of bed or you're not being able, you sit with a book in front of you and you can't read a line because your thought, you just can't concentrate. And this will carry on for weeks. That extreme version of things that are ordinary would also fall into a pattern of a disorder. So they're not necessarily as rare and not necessarily as strange in terms of their behavior as people sometimes think. So, um, out of the variety of human behaviors and experiences, um, which ones are we going to call disorders? There is no hard and fast rule here. Um, there's one school in psychology that is very insistent that for something to be called a psychological disorder, it must have an accompanying biological abnormality. There must be a brain structure that is under imagery different from normal, or perhaps there is something about brain chemistry, an amount of neurotransmitters available, or something that is unusual. Um, but that has not always proved to be um, a usable guide, perhaps because our abilities to do measurement for these kinds of things are not where as advanced as they should be. Also, perhaps because some disorders may be caused by, for example, neural connectivity changes and so on, which don't show up as a biologically unusual marker. Then there is the rule of thumb, which your book mentions, that a psychological disorder is a harmful dysfunction. And by harmful, it means the person is constitute some danger to themselves, so perhaps they can injure themselves because they are feeling so miserable that they want to end their lives. Perhaps because their thoughts are disorders, they don't understand what they're doing, or they're having hallucinations, they're seeing things that aren't there. They can be a danger to others, or or perhaps not bodily danger, but person acting under false beliefs of invincibility and genius may sort of spend their life savings in some harebrained schemes. That all comes under harmful. Then the second part of this criteria is dysfunction, and by this they mean evolutionary dysfunction. So the idea here is some kind of an evolutionary function that our emotions or behavior were supposed to fulfill are not being fulfilled. So a lot of anxiety or fear-based disorders, it makes sense for you to uh, fear heights that you may fall off it. But if it's a well-designed building, and you should be able to see that there is no evolutionarily based risk here, and the evolutionary function of saving you from falling down is not relevant here. If you're not able to inhibit the fear in those circumstances, then I would then suggestion would be that it's this function is deviated from its evolutionary pathway, and then we would call it a disorder. So this would mean, just because things are unusual or strange, you decide to get a set of tattoos and your parents think my child has finally lost it. That would not be a reason for calling it a disorder, even if they were able to say, well, you could risk liver disease or something from uh, getting tattoos or something. So it's hard using this definition to really come out with a criteria for when something has become evolutionarily dysfunctional. Because, of course, in many cases, the evolutionary reasons for behaviors are speculations themselves. So, this too, this decision window or decision criteria for saying this behavior is merely strange, not disorder, doesn't work very well. I personally think there's a lot to be said for the rule of thumb or heuristic of the 4Ds. So the 4Ds are one, a deviant, a disorder. In order to be called a disorder, it has to be relatively infrequent. Right? So simply infrequent doesn't count. If you're a mathematical genius, that's not a disorder. I remember when I was an undergraduate, there was a very famous bank clerk in the UK who on the weekends would dress up as Robin Hood and go to Hyde Park and practice with arrows and climb up and down trees. Uh, and his bank actually made an advertisement based on him that we welcome all kinds in our bank. You'll be welcome as well. So, which was an interesting use of it. But the point is, it's not disorder, even though it's clearly deviant, clearly statistically unusual deviant. Um, Then the second D, so first one it should be relatively infrequent. The second one would be that it is dangerous. Right? So there's some element of risk or danger to oneself and others in the ways that I've explained. Again, this by itself is not a requirement. Many disorders can be problematic, but not necessarily have a dangerous element to them. Then there is dysfunctional. So dysfunctional in this sense doesn't mean evolutionary dysfunction, but it refers to the idea that some major aspects of your life are not being fulfilled because of this disorder. So the idea would be many of us, for example, have some kind of phobia or the other. Most of us would not handle snakes. Most of us would go a pretty long way to avoid getting an injection or going to a doctor. Many of us fear heights. But in order for this to be called a disorder, a phobia, rather than just a general fear, it would need to start messing with the way that we perform our jobs or the way that we carry on our relationship. Um, So if I am clearly ill, but I'm so afraid of getting an injection, I don't go to a doctor, and my illness is getting worse. Now it's become a dysfunctional, and therefore it would meet the condition of being a disorder. Whereas, if you arrange your life without having run into a problem, then it would the fear would exist, but it would not be a disorder, no classified disorder, because it's not causing basic kinds of life functions to be disordered. You guys are students, right? So anything that interferes with your study, if let's say if you have a substance exploration thing going on, right? Okay, everybody, no, not okay, right? Yasser Hashmi said it was okay. No, not okay. Um, but it wouldn't be called a psychological disorder. But if it's come to the point where you can no longer carry on your studies, then one would call it a substance dependency disorder, substance abuse disorder, because it's interfering with the primary function of your life. So if you can't hold down your jobs, if you can't maintain your relationships, your family can't live with you, and things like that, then the rule of thumb of dysfunctional is met. Okay. So deviant, dysfunctional, dangerous, and distressful. So the last D is that most, not for disorder to be called a disorder, very often it's unhappy state for people to be in. They don't want to be that way, and they would rather behave and feel some other way. Now, these are all rules of thumb, and we sort of kind of loosely apply them as a rule of thumb to decide something is a disorder. So, for example, not all disorders are distressful. If you are in the manic phase of a bipolar disorder, you're feeling at top of the world, you're feeling confident, you have delusions of grandeur, you're going to become a millionaire, you're going to become the president of the country. You're not unhappy about it. You don't want, you're not distressed, but we would still call it a disorder. Um, Similarly, in terms of dysfunctional, many people who have personality disorders actually uh, are okay. So some kinds of disorders are not dysfunctional. Um, so if you're cold-hearted, sort of high on psychopathy, we always think of psychopaths as being murderers or serial killers or something. No, a lot of them do very well in, for example, management. Because if you're willing to take, if you have low degrees of empathy for what you're doing, then you are pretty good at firing people. You're pretty good at taking advantage of other people's work and things like that. So that's not necessarily dysfunctional. This is not true of all personality disorders. Other kinds of personality disorders, again, typically people with personality disorders don't think there's anything wrong with them. They don't feel the need to change. But where personality disorders can be dysfunctional. So family members, for example, say, just can't live with this person. It's impossible. Family life is impossible. And that's a disruption of a very basic function that you have. So you have these four rules of thumb, not always involved in every disorder, but you pick and choose and try. In general, the decision for what is going to be called a disorder, and you take those people away and try and cure them, and what kind of pattern of behavior are not going to be called disorders. It's not a biological decision, it is a sociological decision. Society decides that this is not working for us, and this is something wrong and needs to be cured. And this means that a lot of things that you would not consider disorders have been considered disorders in the past. So, for example, in the former Soviet Union, to operate in the black market, to be profit oriented, to be ambitious, to make money, was considered social schizophrenia. That this person's personality is so, thinking is so messed up that they can't work for the good of everyone else as they should as communists, but are self, obsessively selfish, sort of obsessing about money all the time. There's clearly something wrong with them, and it was classified as a psychological disorder. Similarly, I think if you look at the history of a lot of feminists, historical feminists, you will find nearly all of them spent some time in mental institutions because the idea that uh, that um, people, women, should ask for property or should ask to participate in public life or to be have the same opportunities for employment as men clearly showed some disorder in their thinking. Uh, and of course, people reacted badly to it, and that in turn led to escalating emotional crises as well. And a lot of them ended up uh, being classified as having mental illnesses. So clearly, it's society ultimately that decides this we are going to call simply an eccentricity, and this we are going to say is a disease, mental disease that we are going to try and sort out or cure. Um, in a country like Pakistan, uh, disorders are particularly difficult to conceptualize because our society, not having been through an industrial revolution and not having, universal education and things like that, it's very, very variant in terms of subcultures. So identifying whether a behavior or thought pattern is deviant or not becomes very, very challenging. So to, for example, hear voices in sub and to have see visions that of things that are not there would in some subcultures be considered कि ये तो मतलब अल्लाह वाले बंदे हैं इनको ये तो पैगाम आ रहे हैं इसका वही नहीं obviously Muslim country में लेकिन something similar to that and it would not be considered necessarily a symptom or something requiring immediate treatment or something like that. Uh, so again, in terms of women's behavior or the way men and women sit and study with each other as would do if we weren't sitting at home in Corona, would in many parts of the country be considered a mixture of criminal and a mental disorder. These people are morally disordered. There's something seriously wrong with them. So, in a culture like ours, to decide what is a symptom and not by sort of measuring its cultural deviancy is quite challenging. So the deviant criteria is quite difficult to apply in some cases in our country. Um, Now, this is also very important because the consequences of being officially classified as having a mental disorder are very, very serious. So, um, this is the legal part of it is the Mental Health Ordinance 2001, which is a follow on of the Government of India Mental Health Act 1937, I think it was. Um, Basically, if you kill someone, you're a criminal. Yeah, you go to jail. Right? But there'll be a fixed amount of time. You'll spend the time in jail. You will not lose your rights to property. You will not lose. In other ways, you will continue to be a fully empowered citizen, legally speaking. On the other hand, if you are decided, a panel of doctors decides that you are insane, you could be sent to a mental institution for an indefinite period until those same doctors decide that you are sane. And mental health institutions are actually not very good for mental health, unfortunately. While you're in there, you lose your rights to property, you lose a lot of your legal rights in that sense of the word. So the consequences of being classified as having a mental disorder are very problematic. And the way it happens in this country is also quite problematic. So even in a district like Lahore, a very urban district, relatively educated, but outside as well, in district mental health institutions, you will find a lot of unusually large number of women being incarcerated. Now, having spent multiple years in a mental health institution, they very often have mental health problems. But that's not to say they had them when they came in. in many cases, what you have is property issues, which are behind this sort of diagnosis and its legal consequences, which I just mentioned. Okay, so those are the challenges of diagnosis. In a technical, those are sociological challenges of defining something as a mental illness. There are also sort of technical level diagnosis issues. Um, the key instrument that is being used more and more for diagnosis is the DSM-5, the Diagnostic and Statistical Manual of American Institute of American Psychologists Association, APA, version 5. This is what most of our professionals are trained on. An older generation of professionals very often are trained on another instrument called ICD, which is slightly different. It's the British, there's a WHO classification system as well, but DSM is the most predominant. Now it's got particular design philosophies. Um, the DSM aims to, so it lists out disorders, and for each disorder, it tries to give non-subjective, descriptive symptom lists so as to maximize reliability. Right? So the idea would be it would shy away from trying to say something like this person has a weak ego. Remember, we looked at the Freudian idea of ego. Now, saying someone is a weak ego really requires a subjective call by the clinician. And the DSM, this is the kind of call that DSM will try to avoid. So it will typically try and say, must be feeling three of these five symptoms, feeling sad, having poor concentration for at least 4 weeks, 6 weeks for diagnosis of depression. So आपने basically uh, checklist kind of criteria बना लिए हैं to achieve high reliability and to make sure that different clinicians having different subjective calls will not give the same person different diagnoses or something like that. Um, in the DSM, will have um, for each disorder, you will have a symptom list. You will have the typical age of onset. It typically first appearances at this age. So schizophrenia typically has a first appearance in late teenage, early 20s. Um, so has depression. Quite a few disorders begin at this age. It will have predisposing factors. So these can include genetic factors or sometimes traumatic life experiences or something like that. Then it lists out the course of the disorder. Okay, first, if this will happen, then this will happen, and this will happen if untreated. The reason for giving the course of the disorder is, of course, that the clinician might see the patient at any point. They might not come when it first begins, they might come in the middle or towards the end of the disorder, and they need to be able to recognize कि अच्छा हालांकि ये लग तो वो रहा है लेकिन actually उसके उसकी late incident rate है. Then you'll have things like prevalence and gender and things like that. So how many percent of the population gets it? What is the gender ratio and things like that. So basic kind of. Then very importantly, you will also have differential diagnosis का एक box होगा. Differential diagnosis होता है कि if you're seeing these symptoms and you think it's this disorder, there's another disorder that's typically confused with it. So it tells you that if you're looking at this disorder, it's also mixed up very often with that one. So have a look at that one to make sure which one you've got here. So differential diagnosis tells you these are similar looking disorders and you need to understand which one you're dealing with. The DSM, अगर आप बाकी लिस्ट डायग्नोसिस सिस्टम्स देखें तो ये नहीं है कि उन DSM और उनके टोटली डिफरेंट है. मोटे मोटे डिसऑर्डर्स काफी सिमिलर हैं. DSM has a relatively high number of disorders, and we'll talk about that in just a second. Primarily because DSM is designed for use in America, and very often Americans, as we are finding out now, their medical treatment is based on insurance, And lots of insurance policies, if your disorder isn't linked in the DSM, they don't pay for therapy. So there are lots of things that require therapy, um, not necessarily want to call it disorder. So, you know, there's things in the DSM like a maths disorder, mathematics disorder, reading disorder. Those are not mental illnesses. They are things that require therapy and intervention, but they're in the DSM because if they weren't in the DSM in the US, uh, that would be it would be challenging to get therapy for them. Okay, so that's the DSM. DSM is significant overlap with other disorder diagnosis systems, but some of the other ones have a greater reliance on subjective calls, and we can look at whether that's advantage or disadvantage. Certainly, the descriptive tendency of the DSM to stick to objective criteria as much as possible does increase its reliability. It does so by very often increasing comorbidity. Comorbidity is when you are meeting the criteria for more than one disorder. So you have two or three disorders. The objective जो description होती है, for example, anxiety or depression की काफी overlapping, and it's therefore basically if you met the criteria for depression, you're three-quarters of the way of the criteria for some kinds of anxiety disorders also. So that sometimes means this system tends to throw up more comorbidities. अच्छा, अब हम structure of DSM पे आते हैं. DSM has five major axes. So it asks clinicians before they make a diagnosis to collect information on five major lines of investigation. Um, in a sense, the structure of the DSM is forcing a kind of decision making that is mature and informed by the full body of knowledge. Yeah. Very often, when you're studying abnormal psychology, psychology student, और जब abnormal psychology पढ़ते हैं तो आपको ओ पहली बात चीज पढ़ी होती है तो मैं हूँ, दूसरी चीज पढ़ी ओ ये भी मुझे है, because as I said, the for a lot of disorders, they are extreme forms of what everybody feels. Everybody feels depressed, but they don't have major depression, clinical depression. So that's the reason. लेकिन symptoms आपको बड़े similar है. So it's very it's very tempting to just cross off the symptom list and say ये तो classification हो गई. DSM forces you to collect information much more broadly before you come to a decision point. It's in a sense it's not it's substituting for lack of clinical experience by forcing clinicians who are using it to take advantage of this structure, which is embedded forms of lots of clinical experience. अब यहाँ पे I remember मैं एक ज़माने में went to I was teaching abnormal psychology in Lums, and I went with the students to a medical facility, mental health facility in Lahore, a very good one, top one. And I was looking at वो डेली चार्ट्स डॉक्टर ने यंग ट्रेनी डॉक्टर्स उनने बनाए हुए थे. तो एक एक जगह पे 20 उन्होंने पेशेंट ऑब्सेसिव कंपल्सिव के एडमिट किए हैं. अगले पेज पे बाइपोलर डिसऑर्डर के 20 पेशेंट. ये हो नहीं सकता. दीज आर बोथ रिलेटिवली रेयर कंडीशंस. एंड व्हाट यू फाइंड इज कि उस महीने उन्होंने बहुत पढ़ा था और जो पेशेंट आ रहे थे लग रहा था कि ओह ये तो मैच कर गया. दूसरे अगले महीने में दूसरा वाला पढ़ा पेशेंट्स आए उन्होंने कहा ये भी सारे मैच कर गए. That's the kind of mistakes that you can make if you're not sticking to a structure and collecting the full set of information. So, what are these five axes? The axes of information that DSM have. First is the primary clinical problem. So, this is typically the set of symptoms that actually brings the person to the clinician. That Dr. Saab, I can't concentrate, I can't do my daily housework, I can't do this. So these are the things. And these are, you would try and match what the person has with the symptom list for each of the problems that are there listed as main disorders in DSM 5. तो आप उनकी symptom list match कर रहे हैं. That's axis 1, the primary clinical problem. Then axis 2 would be ingrained long-term aspects. These are not symptoms that suddenly appear, but they may be problems that have always been there. So, in ingrained long-term aspects would be something like uh, learning difficulties. Right? So, if a person is very upset and temperamental and having temper tantrums in their work, and you might be thinking maybe attention hyperactive disorder, something like that, but you find they've got learning challenges and they find the atmosphere more challenging to be in. So that those symptoms then suggest कि वो तो actually reactions है, ये यहाँ पे access 2 में problem आ रही है. It's a long standing condition. Dyslexia or other kinds of challenges can be an access 2 problem. Uh, Most importantly, personality disorders. So something like an antisocial personality disorder or a borderline personality disorder or a narcissistic personality disorder. These are the way a person always was. So they are not sudden symptoms, but they can help you decide whether something is a symptom of a primary disorder or does it belong in access to. So if someone has a paranoid personality disorder, they were always like that. They always harboring, I don't know whether my wife is trying to steal my property or something like that. You might be thinking that that is a thought disorder, maybe schizophrenia or something like that, paranoid schizophrenia. But when you find this access to pe hai ye, then you would discount that symptom and say, well, probably this is the way a person always was. That's not something new. It's not a symptom that has suddenly appeared. So access to gives you long-standing conditions that, in a sense, give you a snapshot of who the person was before the disorder appears, and also helps you clarify what is a symptom that has appeared, has a sudden onset, versus what was always there. Then axis 3 is medical conditions. Um, Again, we test this note this for a variety of reasons. For one thing, your medical conditions may, in and of themselves, produce symptoms. So they can be mood swings in a lot of medical conditions. If you have a very serious medical condition, that in turn can lead to low energy and apparently depressed behavior. Person can't concentrate, person has no energy to do anything. Is it depression or not? Well, it could be due to the medical condition. Um, Also, the medications that you take for a lot of medical conditions sometimes can cause some sort of psychological uh, symptoms to appear. So that also is something that you would rule out that this person has seems to have loss of short-term memory. Is it dementia, or is it this medicine they're having that is known to cause short-term memory difficulties or something of that nature? So axis 3 is medical conditions. Axis 4 would be social and environmental stressors. So um, you would look at um, uh, what has been happening in the past year of a person's life. Can what they're feeling be a normal reaction to actually the life that they are living right now? Social environment stressors may, you would think that only negative things count as stressors, but in fact, negative and positive things count as stressors. So, many of you, I presume, wanted to come to LUMS and you got into LUMS. But coming to LUMS is a very stressful experience, even though you're probably happy and enjoying it, right? Even if you're not, I mean, the point is it's a positive experience, it's what you wanted. And then that's the criteria for something being stressful is when it's a change that does not, you're no longer able to go through the day following your habits, that you have to all the time reason and problem solve and tackle challenges in real time. So when you go into a new situation, you know even the simplest thing becomes very challenging. नाम से आप पहले आए थे तो जमील ने presumably आपको तकरीबन बेहोश कर दिया, right? मुझे तो हर सेमेस्टर करती है. So um, that is what's causing the stress there is that your normal habits of operating no longer are, are useful, and you have to stop and check yourself and do problem solving at multiple stages of point in your life. So lots of positive events are count as social environmental stresses. Getting married, for example, to a person of your choice counts. I think उसकी 80 90 स्ट्रेस वैल्यू stresses की 0 to 100 वो स्कोर करते हैं. And getting married is almost as stressful as losing your life partner. So getting a divorce is almost as stressful as getting married in terms of the actual disruptions and score, in terms of the score that's given. So that's axis 4. अब इसके अंदर और भी एलिमेंट्स आते हैं कि कई दफा आप कहते हैं कि अच्छा जी ये स्ट्रेस हुआ है इसलिए दिस इज नॉट अ clinic, it's not depression due to some endogenous reason, इसका exogenous reason है. ये भी clarity आती है. Then there are other kinds of clarity that happens. So for example, if you had lost a relationship or a close partner or family member had died, it's not uncommon to think you've seen them or heard their voices for 3, 4, 5, 6 weeks after that. And you might notice think that's a delusion, which is a symptom. But when you find out, oh, this happened, then you would discount that. Similarly, um, it's known that mourning when someone has died has a time tempo. Uh, and when you lost someone, um, the requirement for being classified as having clinical depression becomes longer. Okay, because 4 हफ्ते 6 हफ्ते 8 हफ्ते चल रही है, तो you would say that this is normal mourning and recovery. It's not clinical depression. It's very sad, of course, but it's not a mental disorder. You wouldn't call it a disorder. Okay, so that's axis 4. Finally, on axis 5, you would have global assessment of function in the past year. How have you been doing in the past year? Now, this again is useful for a variety of ways. So, it may tell you which phase of the disorder a person is in. So, person comes in with slightly delusional thoughts. Sometimes they hear things that happens once or twice a week, and you're thinking, could this be schizophrenia coming on? And you say what was happening earlier, and you find it was happening a lot more, and that would tell you, so they are in spontaneous remission, and you would treat it differently. Or something like the person is all has a disorder and has been getting medication, and you would ask, okay, how are your symptoms? How have you been doing the past year? Are they getting worse, getting better? They're getting better, so you would say, okay, I'll hold the dosage here where it is for that I'm giving, because clearly it's gaining control, and it'll peter out eventually. The disorder will be fully controlled by this current dosage. Whereas if it's getting worse, then you might change the medication or increase dosage or something like that. So that would be global assessment of function. Reasons for that also. So someone comes in with depression and you ask them how it's been in the past year, and they said, "Oh well, 6 months ago I was like on top of the world and I thought I was going to do everything." And now you think maybe we are not dealing with clinical depression, maybe we are dealing with bipolar disorder, because they've had a manic phase in the previous part of the year, and now they're having the depressive phase. And of course, the treatments for depression and bipolar are significantly different. So that would allow you to judge the distinction between them. So that's the 5 axes, and as I said, in successive sort of uh, variants of DSM, you are finding more and more classified number of disorders. Um, for the reasons that I mentioned, and um, partly because they're genuine new discoveries as well. Now there are limitations to DSM. Um, there is a significant danger of overdiagnosis. So in many cases, this objective criteria that the DSM imposes is too loose a category. Um, for example, ADHD, attention deficit hyperactive disorder, you have a series of symptoms, but those symptoms are very similar to boys being boys, stupid, couldn't pay attention, disruptive, ill-behaved, right? Um, and it's sometimes hard to tell whether, or rather, the diagnosis list means too many people are coming into this category. And this is shown or demonstrated by longitudinal studies. So, number of young boys who were classified as ADHD um, were followed up, and you find that for most of them, by the time they're in their late teenage, they no longer have a diagnosis of ADHD. A big chunk of them, a very small number of them do, and those were actually the ones with ADHD. Right? The rest of them were just boys with growing trouble. Majority of ADHD, 80 to 90% diagnosis is for boys. So that's the idea. So um, this idea here would be this descriptive list is perhaps um, capturing too many people um, because for a lot of diseases, the disorder list is found in normal subjects also, just the greater intensity is there and greater disruption is there in subset of people. तो वो capture नहीं करी, वो just tick off करी, ये भी है, ये भी है, ये and you get classified disorder. Similarly, with bipolar disorder, again, I find this in Pakistan as well. People are very high amount of diagnosis for bipolar disorder. Um, and those, in many cases, are mood fluctuations, which we are all prone to, and it's not clear that something clinical is happening there. Then you have the power of labeling. This again is a problem with diagnosis in general. So, when you have meet the criteria for a disorder, in a sense, people assume then that the causality of the behavior that they're seeing is inside the person. And they would stop looking for alternate explanations. So perhaps this person is depressed because actually they're in an abusive relationship. And that's the real problem that we are seeing here, which requires a different kind of intervention. That's one part. And that's a negative part of labeling. So people get labeled with it, and then people start treating them differently. They start judging ordinary behavior as if it is a cause by the disorder. They're second judging everything. Um, in many cases, there's sort of a self-fulfilling prophecy aspect to it as well. A person thinks and starts questioning themselves, and that in turn can give rise to bad habits. For example, rumination, always thinking about the bad things that have happened to you and over excessive focus on those. Um, on the plus side, sometimes labeling and pigeonholing can help. So, person, in many cases, you're feeling, you've been told you're stupid or you're inadequate or you're this, that, the other, and then you find actually it's a disorder. So, Asperger's syndrome, or the autism spectrum of disorders, people often think of them as these are obnoxious people who are anti or who don't have basic manners or basic social skills. They say the most awkward or embarrassing things or something like that. But then you find out that in fact, it's actually a disorder, and therefore you can move on to treatment rather than thinking of it as a personal or moral shortcoming. So there are pluses and minuses to the categorization of any kind, including the DSM. Um, there's a lot of confusion about uh, where a normal behavior begins and ends and where disorders begin. As I mentioned, there's a proliferation of disorders in the various हर DSM का जो version आता है उसके अंदर disorders के number increase होते हैं. So I gave you the example of disorder of written expression or mathematics disorder. Um, these to me might fulfill the deviance criteria कि आपके you're unusually poor at them compared to everybody else. On the other hand, वो जो अगर हम evolutionary dysfunction का criteria लाएं, so they certainly don't fall into that category. Being able to write was not an evolutionary advantage. Being able to do higher order mathematics again was not an evolutionary function. It's not surprising that some people are unusually bad at those. So we want to call them a disorder. I mean, there's a conceptual issue there. DSM has them listed as disorders. As I said, not on DSM, can't get treatment. Um, these categorization systems also sort of, in a sense, create an illusion of objectivity that, this is just an illness in the person. Whereas, as I mentioned, in most cases, there is a sociological control mechanism at work. At the end of the day, society has decided that this behavior we are going to not tolerate, but shove out there and call it a disorder of some kind or the other. And that has its own that has its own sort of consequences. Um, and I gave you the historical examples over there. But we can think of a variety of kinds of contemporary conditions which could um, in future not be called disorders in various ways. Okay, so that would be the shortcomings or limitations of DSM, but generally any any classification system. Um, Now we talk briefly about culture and disorders. Um, there is a considerable consensus on the presence of most disorders cross-culturally. Um, but even with the disorders that are present cross-culturally, their culture provides an interesting context in which the disorders occur. So, a delusion in the US very often would involve you being abducted by the UFO or something like that. Whereas over here, it might involve hearing messages from God or something like that. So, आपका जो कि आपका, for example, Japan में hearing messages from God would not necessarily be a common delusional symptom. So your culture, in a sense, provides the context in which the change, which is the symptom, will happen. This also causes culturally distinct patterns in a number of disorders. So in Latin America and Europe, panic disorders very often, which are extreme fear disorders, involve people feel that they are choking, smothering, and dying, so they can't breathe because they can't. They're so frightened. Um, Basically, part of the reason why a lot of choking happens in panic disorders is breathing is involuntary. You can do it deliberately, but it's primarily involuntary. Breathing out is voluntary. So you basically are so panicked that your lungs are full, but you keep trying to take in air, where in fact what you should be doing is breathing out. But उसमें फिर choking and smothering शुरू हो जाती है. Whereas in the US, the symptoms are felt more as going crazy, going wild. My mind is all over the place. I have feelings of doom here happening, a destruction. So the exact symptomology, subjectively felt symptomology, is different in different parts of the world. In depression, also, what you find is in a lot of cultures, the reported mood is very commonly not the primary symptom. It's strange because depression is, of course, a disorder of mood, and feeling sad is the first part of it. But in highly macho cultures, for example, there's the mood is not reported. It's reported as lethargy, can't work, can't concentrate, weakness, and things like that, rather than being primarily mood as a symptom. Also, in Pakistan, for women, working class women, They again very often tend to underreport the mood, um, because they're not inclined to discuss subjective states. And so they will talk about not being able to do the housework and having headaches or things like that. So you've got to watch out for these cultural differences. In fact, DSM tells you these cultures must have a sad mood for 8 weeks is not a necessary symptom for a classification of depression. Okay, well, very often that will not be how it's reported. Acha. So there are these common disorders which are found everywhere, but there are variations in the way symptomology happens in various cultures. Also, of course, in depression, suicide risk varies a lot by cultural group. So that also how depression pans out is very different. Um, then there are culture-bound syndromes. So particular patterns of disorders which are unique to particular cultures or suggested to be. Amongst them, the Malaysian amok, therefore the word running amok, he's running amok, is a thought disorder, brief thought disorder in which a person becomes uh, disordered thinking, delusional, sometimes aggressive and violent. Perhaps a unusual version of what we would in Pakistan call brief psychotic disorder is called nervous breakdown. In Japan, you have Taijin, Kyufushu. Body parts and functional functions are disgusting to others. It's a kind of a unusual pattern of phobia. Then bulimia, which is a eating disorder, uh, which you have 8, 9, 10,000 calories of food and then vomit them out. So these binging and purging episodes. Um, this is so other eating disorder is anorexia nervosa. Anorexia nervosa is culturally universal, and there's a lot of historical evidence. It's very old in history also. But bulimia is seems to be restricted more to the US, but also what would be called middle class Western culture, which is an international phenomenon, but the core of it is in the US or was developed earliest in the US. And that's where you tend to find it the most. So there are these culture specific disorders as well. So, how do we go about testing these disorders? Well, there are two major methods. You have projective tests. In projective tests, which are being influenced by psychodynamic theories in one way or the other, you give people ambiguous stimuli to talk about or to make or something like that. And then, because the idea is because those stimuli or those instructions are ambiguous, people will project or whatever conflict they're feeling, they'll start seeing it in that image or they'll show it in that ambiguous instruction that they receive. So the commonest kind of a projective test is the Rorschach ink test. उनको आपको ink plots आप ambiguous ink plots आप देखते हैं and you ask what do you see in there, and one person will see a giant crushing a prairie, another person will see two mountains and a stream. जो आपको बुक में एग्जांपल दिया हुआ है रोशाक का वो एक्चुअल इमेज नहीं है. एक्चुअल रोशाक images are kept confidential. Only the clinicians are going to use them, are available to them. And the idea here is people, those are ambiguous images, but there are distinct kinds of patterns that people tend to see there. And psychoanalysts say that each of those descriptions, each of the things that a person is likely to see, अगर आपको ये नजर आ रहा है तो आपकी ये सबकॉन्शियस कॉन्फ्लिक्ट है, अगर आपको ये नजर आ रहा है तो आपकी ये सबकॉन्शियस कॉन्फ्लिक्ट. um, then there are other kinds of projective tests. So tree house person, you make a tree house and a person, and depending on how you make them, um, you read various kinds of internal challenges or anxiety or particular kinds of distress or guilty thoughts into how a person is making them. For a lot of these projective tests, reliability has proved to be a problem. Um, Different clinicians looking at the same test results come up with different readings of what is happening here. And that for a lot of other clinicians as means that those tests shouldn't be used, or at the very least, they should not be depended upon excessively. A lot of these tests open up a conversation and make a person willing to talk about what they're feeling. So they are good tools for opening up and building a rapport between the clinician and the patient. So why have you chosen to build a tree or a house like this? Was your house like this? You've got a little stick figure of you. Do you feel that you are very uh, closed off or very bereft of pleasures of life? So you can, they open up conversation in an interesting way, which can be a clinical advantage. But as a tool for diagnosing that he has this disorder or that disorder, major reliability and validity problems. As an example, there is the famous anatomically correct doll. So children who are thought to have been sexually abused were given dolls to play with which had genitals. And the idea here is if they make them do sexual things, then chances are they've been copying what they were subjected to or what they saw or something like that. It was a projective type of test. We let them play with them however they wanted. Unfortunately, in the original studies, they missed out very important methodological criterion, which was a control study. What if you give these dolls to kids who are you're sure have not been sexually abused? How do they play with the dolls? Well, as it turns out, everybody plays with the dolls. A significant proportion of people plays with the dolls in a sexual way, talks about the genitalia or what you can do with the genitals, even very young children. So again, that sets up a reliability issue as whether something like that, a measurement like this, can be used to um, talk about um, sexual sort of abuse of some kind. So that's projective tests. Then there are objective tests, which are inventories. Basically, we talked about personality. That you have a series of questions and you 1 to 5 to mark करें to how much does it apply to you? Yeah, yes, no करें. And these typically, if they are well designed, have relatively high reliability. Again, not so high that you would not use other forms of clinical assessment, but the reliability is higher than for projective tests generally. इसके अंदर आपकी Beck depression inventory आती है, which is specialized to measure depression, and उसकी आपको it's a normalized instrument, so you know a person should get a score between 5 ± 2. अगर उससे ज़्यादा है तो it's depression. So you have that kind of idea or measurement as well. Um, then the other inventories, a very famous one is MMPI, Minnesota Multiphasic Personality Inventory. That is a single inventory that checks a variety of disorders as well as some having some sub modules to test whether a person is answering honestly, whether they have the mental capability to answer correctly and say and so on and so forth. तो वो भी उसके component है. Then it tests schizophrenia, depression, 8-10 मोटे मोटे disorders जो हैं वो इस inventory से measure हो जाते हैं. So these are the objective inventories, and of course then you have clinical assessment also, um, which of course requires one-to-one investigation. Inventories can be done uh, independently and get a score out. Okay, so now we come to some of the disorders themselves, and we'll start with disorders of the fear system, um, um, of which there are a variety of types, and they are collectively called anxiety disorders of various sorts. Um, Now, this fear, of course, is an evolutionary function that is designed to keep us safe. But what we are talking about in an anxiety disorder is when this system has become disordered. It can be generally overactive. या आपको बहुत ज़्यादा बहुत commonly हो रहा है to the point that it's become dysfunctional, either in the evolutionary sense or in the sense that I talked about in the 4Ds कि आपकी major life functions जो हैं, you can't hold down to a job or it's interfering with your family life or something. But you can think about it being dysfunctional, or so you are having difficulty inhibiting it when it should be. The frontal cortex is supposed to do an assessment and inhibit the amygdala if there is a if there is no valid reason for having the fear. So, in the kind of disorders that you have generalized anxiety disorder, which is a constant feeling of fear, unsettlement, of being in dire circumstances, and the requirement is you need to feel this way for a majority of days in a 6 months period, and it shouldn't be brought on by physical or other causes. So we are not feeling generalized anxiety disorder, although people may have an onset because of the current stressful situation that we are in. But there's an objective thing out there, or you can have, if you have a physical cause, you're sick or something like that, उसको भी जनरलाइज एंजाइटी डिसऑर्डर में नहीं करते, लेकिन जनरली घबराए में है हर वक्त, सेटल नहीं हो रहा, you're feeling that something is about to go wrong and it persists for a very long period of time. You have miserable days for a very long period, over 6 months, majority of days is the symptom. Um, there are a variety of sort of things linked to generalized anxiety disorder. So clearly, what is happening is that you are typically a fear-inducing stimulus should happen, and the amygdala sets off a fear response, and the frontal lobe is supposed to inhibit it. Uh, there are known sort of genetic links for abnormalities in the amygdala and prefrontal cortex associated with generalized anxiety disorder. So, having family members who have this predisposes you. There's a particular kind of childhood temperament that is linked to higher incident rates of generalized anxiety disorder. Um, However, it's not that's not the only risk factor that's linked to it. Having a childhood history of being unable to predict or control a problematic environment also is a significant risk factor for generalized anxiety disorder. So, you uh, divorces in amongst your parents, it's a major thing for kids and they can't control it, or death of a family member or something like that would be a predictor for having later developing generalized anxiety disorder. So that's the learning sort of during a learning or formative phase, having that predisposes you, and possibly it's happening through a cognitive habit of threat assessment, of thinking anything new in the environment, of interpreting it in the form of what risk it poses and how it could cause a disaster in your life. This habit of always thinking that is linked to this sort of disorder. Then um, you have um, panic disorder, um, which is a sudden sort of intense fear, doom, and death, which may last. So very often you can't breathe, and you're suddenly feeling, that everything is closing around you. Everything is incredibly threatening. You might end your life right here. That in sudden onset, and it sometimes lasts for several minutes, sometimes more rarely, it can last for up to an hour, making people shake, sweat, and fear. So much so that the first time people have panic disorders, very often they are mistaken for heart attacks. It's only when the ECG comes out normal that you realize it was a panic disorder after all. Um, Very commonly, they happen during times of stress when there's extreme emotions, extreme fright, but not always. Very often, they can happen significant periods of time after a period of stress has happened. So the case reported in the book was a person went through a potential hijacking on the plane. They were perfectly fine. 2 months after they landed, they had a panic attack. Um, so they, clearly a problem in the amygdala's triggering system for a full-blown anxiety or full-blown fear response. It's also thought there's a cognitive aspect to panic disorders, which is um, a difference in how people habitually notice and interpret their internal body signals. Right? So you have a cup of coffee and your heart will be pounding, and there are people who have a cognitive habit of paying attention to what their body is doing and to be worried about it. So your heart is pounding. Oh my God, what's happening? Am I having a heart attack? But what's happening? This is not this thing. So you're concentrating on it more and more, and that makes you fearful, and that increases or aggravates the signal that you're getting, and that in turn produces the outcome of, of, of the of the of a panic, full blown panic. So that's a cognitive habit that is a risk factor for um, having a panic disorder episode. Um, then you have fears and phobias of other kinds. A phobia typically is a irrational, dysfunctional fear triggered by specific stimuli. So you can, I mean, most of us have some kind of phobia or the other. Um, Snakes will cause us a huge amount of fear. Heights, blood injection phobia is very common. And there's an evolutionary explanation for a lot of these, that these are inbuilt, these are prepared sort of classical conditioned responses, biological prepared classical conditioned responses based on evolutionary history. So snakes were predators for a long time. Heights were dangerous. Blood and bleeding is an indication of danger, right? So for all these reasons, we learn to fear them. But in some people, these fear circuits are overly active, and that in turn starts to cause a dysfunction. So if I'm afraid of heights, that's fine. But if I'm choosing my courses at Lumsden, I only take courses if they're on the ground floor. अगर और मेरा major का एक core requirement जो है first floor पे है, मैं उसकी क्लासें मिस कर रहा हूँ because a lot of times I'm too afraid to go. Now because it's dysfunctional, it becomes a phobia. So that's sort of um, the criteria for phobia. Then uh, you can have a more generalized sort of um, fear, and which is called social phobia, which typically is an intense fear of being in a place where people can see you. Could be the center of attention and observation and judgment. So eating out at a restaurant or making a presentation or something that makes you feel. And again, we are not talking about ordinary levels of fear. We are talking about intense levels of fear. Your hands are shaking, you're sweating, you can't catch your breath, so you're feeling nauseous. That would be the intensity of fear for a social phobia. Um, Different from this, without the element of being socially observed or judged. So वो social phobia की critical differential diagnosis की requirement है. इससे थोड़ा सा फर्क है agoraphobia. Agora is the Greek name for a marketplace, for being in a public place. Agoraphobia is the fear of being trapped in a crowded public place, perhaps in an elevator, perhaps in a crowded classroom or LUMS campus में आपको agoraphobia. So the idea of social observation is not central to it, and you not being able to escape from it. Again, the breathing, the sweating, the nausea, the feeling of weakness. Very often, the onset of agoraphobia is sparked by a panic attack in the fear-evoking place, and then of course, people very rapidly become dysfunctional. So they will avoid going to those places, which means major disruptions in your life. can happen. Um, then again, sticking with uh, your fear uh, systems, you have post-traumatic stress disorder, which is um, uh, the risk factor is a traumatic experience. This can be a burglary or robbery in your house. It was first identified in people who were serving in war in First World War. People were repeatedly exposed to battlefield trauma and they became extremely dysfunctional. Initially, it was called shell shock. Uh, Basically, because the doctors were trying to protect patients, they knew if they called it a psychological disorder, the governments and generals wouldn't listen to them. So they said it's being caused by the pressure changes. Repeatedly, the pressure changes of a shell exploding have damaged the brain, and therefore you have this disorder. So, for women, um, rape or um, uh, sort of that kind of sexual, um, being victim of sexual aggression um, is also a very common cause for this. Its symptoms are extreme stress symptoms. Insomnia, a person is agitated. Uh, they have involuntary, intrusive thoughts, including thoughts of what has happened, reliving the trauma, uncontrolled sort of re experiencing of the trauma, a general detachment from those around them, increased arousal. So, you clap and they sort of scream and jump in very high startle response, it's called, when you're startled of extreme startle response. These are all symptoms, and particularly if they persist beyond 1 month and are disruptive of function, then we would call it a post traumatic stress disorder. Um, there are known genetic predispositions. So, in identical twins, um, you have patterns of pre-existing personality, the patterns of anxiety and impulsive aggression are, if you have that earlier and then you have a traumatic experience, you have a much higher incident rate of getting post-traumatic stress disorder. General lowering of mental health in any way, if it's less than robust, puts you at high risk for disorder. Um, the largest study for this was the Israeli army. It's a conscript army, so general population serves, and they all do a mental measurement as they join to classify them. कि यहाँ serve करें, यहाँ serve करें. And what they found was after the Israelis invaded Lebanon, some of them suffered post-traumatic stress disorder, and they looked at who did or didn't suffer it and tried to get correlation with earlier pre-existing conditions, and they found any kind of pre-existing mental health condition and you have a higher vulnerability after the stressful event for having a disorder. Um, Probably because your ability to cope with the stress and the ability to cope with the memories of the stress are poor. Um, High IQ is negatively correlated with having a disorder. So, partly because your coping skills with high IQ with the stressful event itself are better, and also with these stress produced by it, the memories and so on, you tend to cope with it more effectively if you have high IQ. So that's a protective factor. Um, One sort of brain feature uh, linked with it is hippocampus, a smaller than normal hippocampus. Hippocampus, if you remember, is the heart of episodic memory. Your autobiographical memory, this happened to me, that's happened to you, thinking back about yourself in a particular situation. That memory is stored in the part of the brain called the hippocampus, and a smaller than normal hippocampus and a stressful experience together is a high predisposition factor for having a post-traumatic stress disorder. Okay, so we will next pick up on obsessive compulsive disorders, which are the last kind of fear based disorders, and we'll continue on to mood disorders, personality disorders, and schizophrenia in the next lecture. So that's all for now, and thank you.